Hello and welcome to the Imedex Best of Day series. My name is Dr. Joseph Mikhael. I'm a hematologist at Mayo Clinic in Arizona, and it's my pleasure to be the chair of these sessions as we review updated information at our annual hematology meeting. It's my particular pleasure today to invite Dr. Neil Kay with us. Neil Kay is a hematologist known internationally for his work in CLL based at Mayo Clinic in Rochester. Welcome, Neil.
Thank you.
It's great to have you with us today. This has been really an extraordinary meeting here in San Francisco. We've seen a number of updates in benign hematology and malignant hematology. And there's always a great interest in CLL. I noticed that swarms of people were going into the CLL session. So we're interested in filling us in a little bit as to what may be changing the landscape a little bit in CLL. So why don't we start with upfront therapy. I know that there have been some recently approved agents in the relapse setting. Ibrutinib, which I'm sure we're going to be talking about soon, but as well as, and I want to make sure I pronounce it correctly, idelalisib.
Beautiful.
And tell me a little bit about an upfront study that was combining idelalisib with rituximab in the frontline setting for patients with CLL.
Yeah, so originally, as you're aware, the phase 2 and phase 3 studies with idelalisib were really for relapsed refractory. Now, at this meeting, we're beginning to get information on treatment of upfront patients, albeit not very large population. The focus has been primarily on relapsed refractory. However, the news there is that the response rates look to be somewhat higher than the relapsed refractory, perhaps in 10 or 20% higher than that, so around 80%, 90% response rates with some CRs, some complete responses. Most of the responses still seem to be partial responses, but at least we're now beginning to see complete responses. And the interesting information that's also coming out of these trials, both for relapsed refractory and for the upfront, is that the longer these patients are able to take the signal inhibitors, whether it's idelalisib or ibrutinib, the deeper the responses seem to be.
So with this idelalisib and rituximab combination, do you see this as something that we're likely going to be using in the frontline setting before too long, or as one of the options for patients, or do you think those response rates were not impressive enough to change practice?
That's an important point. And currently, the standard approach, the gold standard approach for upfront progressive patients would really be chemoimmunotherapy still. And the response rates there are 90% with CR rates 40 to 50%. We're not reaching that.
So those are combinations like PCR, FCR, FR.
Yes.
Okay.
Bendamustine, rituximab perhaps as a close second to those. So I think it won't be so immediate that we'll see approval for upfront, but the combinations nevertheless are going to continue to be tested as have initially been reported here. I'm certain we'll hear more about that in the next year or two.
And before we leave that abstract, how about the side effect profile? You know, we have a better characterization of what happens to these patients in the relapse setting, some of the GI toxicities. Can you expand on that in the upfront setting? Are they similar? Are they less severe, more severe?
Yeah. Well, a couple of things about that. First of all, happily, we don't see bone marrow suppression to a great extent or immune suppression. In fact, there may be immune enhancement in patients who are particularly getting ibrutinib. The toxicity profiles are similar in the upfront to the relapse refractory so far as has been reported. Predominantly those are, and I'm just putting both idelalisib and ibrutinib together here.
Okay. Not
Not all of them have the same profile exactly, but diarrhea, unfortunately, has been an issue. Some patients have been reported to have actually colitis. There has been some reports of atrial fibrillation, rash, liver enzyme elevations, things that we don't typically see with the chemoimmunotherapy. However, I would add that for the most part, these adverse events seem to be low grade. And the other aspect that's important is that if the patient's responding and they come off a signal inhibitor and the AE resolves, it appears that you can put them back on the drug and continue. So it's not quite so ominous as it may sound.
So for a lot of these patients, they were able to go back on the therapy despite the colitis or liver enzyme elevation, assuming it wasn't high grade. As you
I can't tell you the exact percentage, unfortunately. Okay. Currently, it's not, I don't think it's that well defined, but I would think that for AEs that are in the lower grade that the majority of those, once they come off for a sufficient period of time to let the toxicity resolve, they would be able to go back on.
So maybe not immediately ready for prime time. We'll learn more about the AEs, but another option. We always want more options, obviously, for our patients in the front line.
Absolutely. The other point I should make about these trials for upfront or relapse refractory are that happily they do involve more the community-based type patient. They're older, perhaps in the age bracket of 70, versus the typical median age for the chemoimmunotherapy trials where they were more 50, in the high 50s and 60s-year-old. The other thing is that they seem to be working in high risk, even patients with 17P. So that's good news, and the updates on the information that I've seen at this meeting looks very encouraging, that they continue to show responses in the unfavorable patients.
Okay, great. Well, before we leave upfront setting, I know that you've been involved with some work with the PCR regimen. Often people think of FCR and FR and bendamustine rituximab, as we've mentioned, but PCR has been an also highly favored regimen. Any updates on the PCR? I understand you're combining it with bevacizumab.
Exactly. And the rationale for that has been that we believe that angiogenesis does play a role in progression. And so we have just recently completed a trial of PCR with or without bevacizumab, the anti-VEGF agent. And the response rates, overall response rates are in the 90%. But it appears that the patients getting PCR along with bevacizumab have higher levels of complete responses than do just the PCR patients alone. And that encourages us to think that the pentostatin-based regimens, which in our hands, and I think other people's hands too, have also used this, seem to be kinder and gentler than other
FCR.
than FCR. You can give them to older patients and get them through 6 cycles if that's what's required. And in addition, many patients who have somewhat compromised renal function seem to be able to accept 6 cycles of pentostatin-based regimens. So we're encouraged that that is a nice addition to the CIT regimens for.
And so might be able to deepen that response. Are you measuring things like MRD status and so on to further evaluate the depth of those CRs?
Absolutely. We want to get to MRD negative status. Certainly that would be the goal for CIT regimens because of the accumulating data, and actually that has been reported here in updates by other investigators in Europe, in London, in England, that if you get to an MRD negative status, interestingly whether it's a CR or a PR, if they're MRD negative, and again most of this has been we're using CIT regimens, the patients do extremely well. In fact, the CR patients who are MRD negative, the PR patients who are MRD negative actually do better than CR patients who are MRD positive. So reaching that MRD negative status using sensitive flow cytometry is a very desirable goal.
It's definitely an emerging theme in heme malignancies. I spent a lot of my time doing myeloma, and we've been having that same kind of notion that even patients in CR that are MRD positive don't have the same outcomes as those in either a PR or a VGPR who are MRD negative. So I guess kind of the take-home message here is, again, bevacizumab may not be fully ready for prime time, but this might be an opportunity to deepen responses. And almost whatever regimen is used, the depth of that response with MRD negative status is a very important prognostic marker in the future.
It is, although I would hasten to add, Joe, that for the CIT regimens, MRD negativity is obviously very desirable, as we just discussed. However, for the signal inhibitor-based protocols, MRD negativity, as we now know it, may not be exactly the same. Okay. And I think that again, we'll be hearing more about the change in MRD and the kinetics of that change with these signal inhibitors. They are complicated by the fact that we see lymphocytosis often in the initial phases of treatment, and in addition, because of the prolonged duration of taking these drugs for a certain, perhaps one might consider a very lengthy period of time, perhaps 12 months or more before you get a maximal response. The MRD status for them may be different than it is for CIT.
Great, excellent. Well, why don't we shift our focus a little bit to relapse disease? This is obviously where more things seem to be emerging in the CLL realm. We talked a bit about idelalisib with both in the upfront setting. Well, now let's talk a bit about it in the relapse setting in combination with rituximab. Was there an update on that combination?
There was an update, And the update did continue to confirm the excellent overall response for relapse refractory in the 70 to 80% range. Again, most of these responses are partial responses, but some CRs. The toxicity profiles do not appear to be any different. I think that's encouraging. The progression-free survivorship is still very prolonged. Again, these are patients who are high risk and aged. So very encouraging data with the update. Excellent. And there was also an update for an older trial as well, the ibrutinib versus ofatumumab.
Just before we jump that trial,
Yes.
the question I have, just so our audience is clear, no, of course,
Yes.
is what is the exact FDA indication for idelalisib?
Very good.
I'm learning.
You are learning. So the exact indication for idelalisib and rituximab is for relapse refractory CLL, not for upfront. And
any relapse refractory, or do they have to have X number of lines prior? Or
not to my knowledge, no. Just relapse refractory.
Okay, so let's talk then about ibrutinib. Obviously, it's had tremendous press over the last several years in multiple lymphoproliferative diseases, especially in CLL. And you were saying the RESONATE trial, the one that compared ibrutinib to ofatumumab. Tell us about that.
Yeah, so those results were also presented as an update, and the overall responses clearly favor ibrutinib, perhaps 80%, roughly 80% versus 17 to 20%.
Wow.
Yeah, and again, there the toxicity profiles look much as we've discussed earlier. There are SAEs that are definitely different than CITs, but it looks like it's very tolerable and manageable.
Great, excellent. Now let's think a little bit about some of the newer phenomena that are coming. I know that things wax and wane. There's some years with a whole series of new agents, but there are three particular agents that I'm interested in hearing a little bit about from you, Neil. The first is that delta and gamma inhibitor, the sort of double hit approach. The second is going to be the CAR T-cell story, because everybody wants to talk about CAR T-cells and understand what role it might play. And then maybe a little bit about ABT-199, because I know that across many heme malignancies that's been of interest, but really started with CLL. So why don't we start with that? I think it's called IPI-145.
IPI-145, much easier to pronounce.
Yes, it's easier than idelalisib.
It has another name I can't pronounce either. But so the IPI-145 is an interesting biologic approach in that it not only inhibits PI3 gamma, PI3 delta, but PI3 gamma, but also PI3 kinase delta. And both of those can be operative in B cells. But the interesting thing also about the PI3 kinase delta is that it may impact also on the microenvironment. It may impact on T cells, potentially has an influence on macrophage polarization. And so this
targeting both the tumor and its environment
exactly.
At the same time. Excellent.
And so this approach is being tested now in relapse refractory patients. And the data presented at this meeting looks like there are definitely responses, fairly, again, in the overall response rates may be similar to the other signal inhibitors we've talked about earlier. Currently, there are trials that I know are being looked at in terms of combination with that agent as well. Given that it affects the environment in a favorable way, and perhaps the other drugs may not impact on the microenvironment quite as much, this drug may start to emerge as a very favorable drug for use.
Were there notable toxicities with it? Or is it still a little bit too early to know?
It's a little too early to tell. My guess is it will be very similar to the other signal inhibitors.
Okay. Well, then let's talk a bit about CAR T cells. I know it was an incredibly hot topic here both 2 years ago and last year at our annual meeting. Any updates on that? Anything that is really going to change the way we do things in CLL?
Well, there was one session that updated the hematology meeting group on in regard to CAR T cells. The encouraging news is that there are CLL patients who respond brilliantly to CAR T cell infusions. Unfortunately, it's not 100%, and so that's not the most heartening news at all. But my bias about that is that the graft versus leukemia effect in CLL is extremely important, and that's as witnessed by the fact that bone marrow transplantation may be the only way to permanently eradicate CLL, and that does employ GVL, and the CAR T cells are a form of GVL. The approach ultimately to maximize CAR T cells will continue full bore. Okay. And I think, again, in the next year or two, we should surely be hearing more about that. It's going to, I think it'll be in the menu
Okay.
for treating patients in the
So a
future.
little maybe further off than some of these other approaches, but definitely still
Yeah.
encouraging.
Need to refine somewhat more the molecular makeup of the CAR T cell without getting into great detail, but there are wonderful people doing those studies, and I'm sure we're going to see
Great.
improvements.
Excellent. Are you one of those wonderful people?
I'd like to be,
You'd like to be. Okay, fantastic.
if enough funding.
Nice. Well, let's talk a little bit about ABT-199, because I know that that has had a lot of press in CLL and in other diseases. Is there anything new in the ABT-199 world?
Yeah, just to update on that. So the ABT-199 originally as used in CLL was a little problematic because of the, well, more than a little problematic, because of the very obvious tumor lysis syndrome where patients were really needing to be managed in an intensive care-like setting. However, the recent reports, and one report that is from Australia, does show that with a modified dose of ABT-199 in combination with an anti-CD19 monoclonal, that it's safer. I believe the dose now is 400 milligrams of the ABT-199, and the incidence of TLS looks to be markedly reduced, and the response rates are approaching 70%.
So still good response rates, because as hematologists,
Yes.
we kind of love and hate tumor lysis. We love it because it tells us it's working,
Right.
but we hate it because it can be, of course, so impactful, especially in renal function. So they've been able to maintain a reasonable or a good response rate with less tumor lysis at that reduced dose?
Insofar as I saw, yes, and you're right, we do like to see, we love and we hate to see tumor lysis. It obviously indicates a very effective agent, but the metabolic issues and the toxicities can be problematic in the past. This study does make me feel much more encouraged that it's manageable, perhaps more in a not necessarily a community practice setting yet, but I think ultimately it may be.
Great, excellent. Well, our time is almost up, but before we go, you can never have a fulsome discussion of CLL without a discussion of prognostic factors. And I understand, not necessarily being presented at the meeting right now, but very recently there was some work published exploring further prognostic indices for CLL. Mm-hmm. Can we wrap up by you telling us a bit about that, Neil?
Sure. Succinctly, I will tell you that our group, headed by Tate Shanafelt, actually, along with the German CLL study group, has developed what's called a prognostic index. And what it does is compile both novel and traditional prognostics into one index where currently eight factors, prognostic factors that have the most impact in terms of overall survivorship or progression-free survivorship have been put into a model where scores are assigned to each factor. Okay. And for example, 17p, very high risk parameter, is given a score of 6. Oh, wow. On the other hand, beta-2 microglobulin might be given a score of 2. So and these scores are related to hazard ratios that have been developed via a multivariate analysis in very large numbers of patients, both on clinical trials and more recently for early stage patients. And what's interesting about that is that you can now stratify either early stage or progressive patients into 4 subgroups using this index into extremely low risk, intermediate risk, high risk, or very high risk.
So literally patients across the CLL spectrum.
Well,
from upfront to later.
Upfront to progressive,
disease.
We would love to be able to apply it to relapse refractory. I don't think we've proven that yet.
Okay.
But there is going to be, and there was actually a meeting at this National Hematology Meeting where further evaluation using this, what we would like to, I believe it will be called International Prognostic Index. Okay. So it will be studied further in all of the cohorts, including relapse refractory, and I think that the community within the United States will be hearing more about this index.
Great. So we've talked about a lot of things today. It sounds like there haven't been maybe some big home runs in CLL in the last little while, but a series of doubles and maybe even a single or two, and that people should be looking a little bit more for some of the therapies we use in relapse to be brought to the upfront setting, and now with this potential international prognostic index, that we might be able to prognosticate more intelligently our patients with CLL.
Yeah, I think that's well summarized. I guess I'd put it in more of a category of slow but steady
Slow but steady.
improvement
Great.
in counseling and treatment.
Okay. Kind of sounds like CLL, slow but
Slow
steady.
but
in
steady,
general.
yes.
Excellent.
Kind of like it.
Well, thank you very much for being with us,
My
Neil.
pleasure.
It's always a pleasure to have you, and thank you very much for joining us for our Imedex Best of Days series here at our annual hematology meeting. It's a pleasure always to have you. We trust that this series has been practical and helpful for you. Please continue to watch as we cover all areas of malignant and benign hematology, and have a great afternoon. Thank you.